Assalamu alaikum everyone. My name is Dr. Faisal Hanif. I'm giving a talk on rationale of living donor liver transplant in our country. I'm currently working as head of liver transplant surgery at Bahria International Hospital. The prevalence of hepatitis C in our country is massive, anywhere between 2% and in some districts, unfortunately, up to 30%. The commonest genotype in Pakistan is 3, followed by 2. In high-risk patient population, the seroconverse prevalence of hepatitis C can be seen in up to 50% of patients in certain districts. In patients with liver disease, it is the most commonest virus, and in some patients, in some areas, it is up to 80% in patients with chronic liver disease. Another major killer of Pakistani population is hepatocellular carcinoma. 3.7 to 16% of all tumors in certain populations in Pakistan are now HCC. And the most unfortunate problem is that HCC is diagnosed in very late stage in Pakistan. And that is why 90% of the patients fall into the categories of palliative management in the form of TACE or sorafenib or immunotherapy. And only 10% population is suitable for curative treatments such as liver resection or liver transplantation. In general, indications of liver transplants, other than hepatitis C and HCC, the commonest one is Hep B, but then there are certain metabolic conditions and rare tumors which may require liver transplant as well. According to a survey, there is at least 10 million patient population suffering from chronic liver disease, and 2 million at any given time frame require liver transplantation in Pakistan. The general criteria which we use to assess patient for listing them is called Model for End-Stage Liver Disease score. And usually if the score is above 15, patients are considered for liver transplantation. Similarly, Milan criteria is used to list patients with hepatocellular carcinoma, which means that if there is one tumor less than 5 centimeter, or if there are up to 3 tumors, each less than 3 centimeter with no vascular invasion, those are considered as suitable patients for liver transplantation. Now there are several other criteria, but I think they are beyond the scope of this talk today. With a country having 2 million people requiring liver transplant, there are only very few active centers performing liver transplantation in Pakistan. So in Islamabad, Shifa International Hospital and Military Hospital, and Qaeda International Hospital, there are 3 centers. In Lahore is PKLI, Bahria International Hospital, and Sheikh Zayed Hospital. In Karachi is Gambit and SIUT. The transplant is usually of 2 types: cadaveric donor and living donor liver transplant. The cadaveric donor liver transplant is a preferred choice and is most commonly performed in developed countries. The most important thing about cadaveric donor liver transplant is that there's nothing to worry about the donor. The graft is big size, the vessels are large, usually no extravascular reconstructions are required, and therefore there are lesser chances of vascular and biliary complications, and there are lesser chances of small for size syndrome. Whereas in living donor liver transplantation, the donor's risks are there, the graft size is smaller, the vessels are smaller, and there are multiple vascular and biliary reconstructions required. There are more chances of small for size syndrome along with vascular and biliary complications. Then why not? We should just opt for cadaveric transplant in Pakistan. Cadaveric donation process and cadaveric related transplantation require massive infrastructure at national level. They are brainstem death donors. They have confirmed brainstem death. Families are informed. ICU teams are trained. And then there should be a central allocation system to direct those donors to suitable recipients. The donor hospital staff should have enough training to manage and deal with these donors. There is need to mobilize a donor team to retrieve donor organ and a recipient team to prepare the recipient at the same time. And the time is critical because each organ has to be transplanted within a certain period of time to minimize the cold ischemia and adverse events. And unfortunately, this type of infrastructure doesn't exist in our country at the moment. So this is an organ retrieved for transplantation, and generally the cadaveric liver transplant, full graft is implanted. This is a graft with IVC reconstruction and standard portal vein, hepatic artery, and biliary reconstruction. Living donor liver transplant is a complex process. You have to assess the donor with the help of CT volumetry and vascular reconstruction. You want to know what is going to be the size or the weight of the graft and whether that is suitable for that particular recipient. And you also want to know the remnant of the liver, if that is going to be safe enough for the donor. And you do all these measurements with the help of CT volumetry. You can perform vascular reconstruction. For example, in this case, this is vascular reconstruction of the celiac axis, where you can see a right hepatic artery, accessory right hepatic artery, and the left hepatic artery. And then you can plan your arterial reconstruction accordingly. This is portal venous reconstruction of the hepatic veins. This is right hepatic, and this tributaries, middle hepatic, and left hepatic vein. This is reconstruction of the biliary system with the help of an MRCP. You can see the right duct, left duct, and common hepatic duct, and then continuity into bile duct. In living donor liver transplant, sometimes you come across these anomalies. For example, this patient has anomalous right-sided portal vein with extrahepatic division into the anterior and posterior sectorial portal veins. And this type of anomaly requires reconstruction for implantation purposes. Similarly, sometimes you can have two ducts separately going to the right lobe of the liver, needing separate reconstruction, or you can have middle hepatic vein draining segment 5 and 8 needing reconstruction. This is a right lobe graft. You can see cystic artery, right hepatic artery, and cystic duct, common bile duct, and both lobes are splitted, are transected, but the vessels are still intact before the graft retrieval. This is a segment 8 vein drainage with the help of a synthetic graft in the right lobe donor, and the same graft after reconstruction and implantation on the IVC. This is partial middle hepatic vein reconstruction. This is the inside to middle hepatic vein, and this is the reconstructed part in order to prevent a small for size liver. Arterial reconstruction can be carried out with high-powered loops or microscope. This is an intraoperative cholangiogram of the liver transplant to make sure that biliary reconstruction is satisfactory. And this is the same patient with double portal vein. This is posterior venoplasty and construction of a Miller's cuff to join two portal veins and converting into one anastomosis for implantation. So as a conclusion, cadaveric donor liver transplant needs massive infrastructure. And that is the most difficult aspect to achieve in our country. Living donor liver transplant is technically more challenging for the surgeons, but the infrastructure is usually not at national level. It can be set up in one tertiary care hospital. It requires expertise of surgical team and the relevant other professionals. But the infrastructure requirement is not as big as it is in the case of cadaveric transplants. Government and the society, including all stakeholders, need to work really hard for those millions of patients who require liver transplant so that we can develop more and more centers, not only for living donor, but also for cadaveric transplants. We should not forget that living donor, or for that matter, cadaveric donor liver transplantation, is a gift of life to your loved ones. Thank you.